Alors voilà, sans plus tarder, j'ai le plaisir de présenter le prochain conférencier, professeur Yves HENROTIN de Belgique directement, qui va nous parler des approches non médicamenteuses dans un contexte de douleurs arthritiques et d'arthrose plus spécifiquement. Merci beaucoup, professeur HENROTIN.
Thank you, Guillaume. I'm coming from the French part of Belgium, and I have decided today to present my talk in English, but with a French accent, and by this way I hope to satisfy everybody in the audience. Well, I'm here because I was, of course, invited, but also because I'm really a supporter of NPI, and through the Osteoarthritis Foundation, and I'm the chairman of this foundation, this is exactly what we try to do. This is also to implement NPI in the life of people suffering of osteoarthritis. And I will try to convince you that NPI are very important for managing OA patients. I don't know if everybody know exactly what is osteoarthritis, but this is the most common joint disease, and this disease is characterized by the progressive loss of the cartilage. The cartilage, this is the smooth white tissue that you can see at the extremity of the bone, and thanks to which your motion is not painful. But clinically, this disease is also characterized by a pain, mechanical pain during motions that progressively become chronic and even during rest, and also by decrease of functions, the range of motions of the joint. At this time, 600 million people suffering of osteoarthritis worldwide. This is huge, and this is the seventh cause of your life with disability. What is very worrying is that in the next decade, this number of patients will dramatically rise, and the scientists expect 1 billion of people suffering of osteoarthritis in 2050. This means that they will have some inequalities between individuals and also between countries in terms of care for this disease. And this is the reason for which the FDA decided in 2018 to recognize osteoarthritis as a real disease for which there is no yet cure. Of course, osteoarthritis is a disease related to aging, and the prevalence of this disease increased progressively with age to reach around 70% after 7 years old. And you can see that mainly women are affected by this disease after menopause. But this is not only a disease of aging people. In Europe, 43% of the patients are age under 65. And what is very important to note is that this disease is associated with an excess of mortality, and mainly due to cardiovascular disease. The reasons, of course, this is because osteoarthritis is one of the main causes of sedentarism, but also because osteoarthritis is associated with a lot of comorbidities. And you can see here that 67% of the OA patients have at least one comorbidities, and among the 10 more frequent comorbidities associated to osteoarthritis, you can find the 3 main determinants of the metabolic syndromes: diabetes, dyslipidemia, and also hypertension. What this means? This means is probably the second reason for which osteoarthritis is linked to an increase of mortality. And what is interesting is that there is no a real link between the metabolic syndromes and not only the incidence of osteoarthritis, but also the worsening of the disease. And this slide is very important because more you have components of the metabolic syndromes, hypertension, dyslipidemia, and diabetes, for example, more you accumulate that, more you risk to worse osteoarthritis. What this means? This means that when you treat an OA patient, you have also to treat the comorbidities. And not only the physical, the biological comorbidities, but also the psychosocial comorbidities. And I would like just point that osteoarthritis is first pain experience during motions. And this is the first reasons of visit to the GP, to the physician, this is the pain. And if the physician told to the patients, oh, you are hard, I can do anything for you, you create catastrophism, which is also a factor for kinesiophobia, for fear of motion that create disability. And this is one of the reasons of a lot of psychosocial comorbidities like isolation, like, for example, depression, anxiety, which are all amplifiers of the pain. And the pain, this is also, as I told you before, the first cause of sedentarism, which is not only a cause of factors of metabolic syndromes, but also one of the key factors of functional capacity decline in aging people. What this means? This means that when you treat osteoarthritis, you don't treat only a joint, but a patient in a whole. And this is exactly what I have tried to summarize in this planetarium representations of the OA physiopathology. You have two orbits, the blue one and the red one. The blue one, this is the biopsychosocial approach of the disease. And the red line, this is more the biological one. As I explained you, the metabolic syndromes is a cause of incidence and progressions of osteoarthritis. But what is very interesting is that a lot of factors which are released from the OA joints, including the pro-inflammatory factors like cytokines, prostanoids, also contribute what is called the systemic inflammations and mainly the aging-related inflammation, which is one of the main causes of cardiovascular disease, for example. And we can also add among all these reasons of this holistic point of view, this is the dysbiosis, which is also a cause of inflammation, of systemic inflammations. Well, this means that to optimally treat OA patients, you need to have a patient-centered approach based on three main pillars. The first one is the management and the identifications of the risk factors and the comorbidities. The second pillar, this is the pharmacological modalities, and the non-pharmacological modalities is the third pillars. And you have to use this three approach to decrease, to relieve the symptoms. At this time, there is not yet treatments that may have disease-modifying activities. And on this slide, one important point, this is the two arrows. The two arrows means that you cannot dissociate it pharmacological and non-pharmacological approach. And the pharmacological approach has to be used to facilitate non-pharmacological treatments, like, for example, physical activities. And inversely, the physical activity has to be used also to decrease the consumptions of drugs with a lot of adverse effect. Well, this is exactly what is summarized in this algorithm published by the main osteoarthritis scientific society, the ORC. And you have two approaches. A global approach, which is the core treatment. This is the left panels. And in this left panel, you find only NPI. no pharmacological approach. This means that the core treatment of osteoarthritis are NPI. And you have education, you have physical activity, exercises, weight control, and you have to select for all the patient, whatever the age of the patient, whatever the health status of the patient, you have, after an assessment of your patient, to select one or more of these modalities. And on the right panel, you have the patient-centered approach, including the pharmacological approach. And the pharmacological approach is very limited. The first options, this is topical NSAIDs, no more. And if you don't succeed with topical NSAIDs, you can use oral treatments, oral NSAIDs, duloxetine, for example, but also intra-articular treatments with corticosteroids or HA. But what is very important is that some of these treatments, including corticosteroids or NSAIDs, have a lot of adverse effects. This means that you have to limit their use in the time and to use, for example, NSAIDs at the minimal efficient dose. And finally, if you don't succeed with these oral treatments, you can then refer your patients to, for example, a pain clinic and an orthopedic surgeon. Well, we have very limited options, pharmacological options. Therefore, we need of NPI for treating the patients, and we can use modalities coming from the three main group of NPI. The first group, this is of course the group that will be used for the preventions. Is it possible to prevent osteoarthritis at the different stage of the life, including early during the infants by preventing deformities, for example, but also by preventing increase of weight. You can also act at on the teenagers by preventing, for example, spore injury and by treating well a spore injury, which create joint instability. And you can also act late in the life in the aging people, for example, in the woman and menopause for controlling the weight, and also in older people by treating sarcopenia. This is important to note that we can prevent disease. Unfortunately, we have not yet enough implemented prevention action. Well, concerning the physical activity, the three main physical activity recommended to treat osteoarthritic patients are the land-based structure exercises, the aerobic exercises, and the mind-body exercises. And I will shortly explain you what we can do with these three modalities. If we look at the land-based exercises, the key message is that we have to use different types of exercises: strengthening, stretching, aerobic exercises, but also neuromuscular control. And we have to select one or two types of exercises according the needs, the preference of the patient, but also according the physical status of the patient. And the selection is very important because according what you will select and also the type of exercises, you will win the adherence of the patients to the physical activity, which is at this time one of the main barriers to physical activity in the treatment of OA patients. Aerobic exercises, the EULAR, which is the European League Against Rheumatism, recommend to use the past WHO recommendations for physical activity. You know that this recommendation changed recently, but in clear, we have to recommend moderate intensity exercises, at least 3 times per week during 30 minutes. And for example, moderate intensity activity, this is working at 4.5 kilometers per hour. Or you can recommend to use vigorous intensity exercises like, for example, running. And finally, you can combine in your program the both type of exercises to reach of course, the levels of physical activity recommended by the WHO. And this is very important to follow this recommendation because I remind that the physical activity is the main way to prevent and also to decrease the chronic pain. And I remind you that OA patient is first a chronic pain patient. By releasing endorphin, serotonin, you can control the pain in this patient. Mind-body exercises. There is recently a meta-analysis investigating this type of exercises, and you can see that was mainly Tai Chi and yoga. And what is very important is to note that the meta-analysis clearly conclude that mind-body exercises can improve the pain, the function, the stiffness, the mental health, the depressions, and the motor ability of OA patients. Well, based on that, there are some multimodal programs that have been proposed by scientists, and the most popular to treat OA patients are the GLAD program, the Good Life with Osteoarthritis program that come from Denmark. And what is interesting is that they have now a large cohort of patients following this program, which include neuromuscular sessions of neuromuscular exercise sessions and education sessions, and they deliver this program during 8 weeks. And what is very interesting is that whatever the level of activity of the patient at baseline, the patients have a benefit on pain after 8 weeks of treatments, whatever their levels of activity at the beginning. But the most important message is that based on this only 8 weeks exercises program, you can have an effect at least 1 year after the end of the program. This means that you invest 8 weeks of your life in active treatment, and then after you can have a relief of your pain during 1 year. Another program was the NEMEX program, which integrates aerobic exercises, strengthening exercises, neuromuscular one, during, again, 8 weeks, 2 sessions per week. Each session is around 60 minutes, and they have compared the efficacy of this program with pharma, only explanations of the mechanism of actions of drugs. And what is interesting is, again, to note that the exercises program decrease the ergofunctionals, improve the ergofunctional status of the patients 1 year after the administrations of this short program of exercises. And this is probably why the treatment have to be, the exercises approach have to be more implemented in the treatment of OA patients, because it was clearly demonstrated that exercises program are as efficient than NSAIDs. And this is what is demonstrated on this, in this meta-analysis. As efficient than NSAIDs, but safe and well tolerated. This means that you can decrease the adverse effect induced by NSAIDs by implementing physical activity in the life of your patients. The problem, this is the compliance, this is the adherence, this is the observance. And we have to improve that probably in the next decade through, for example, applications that could help that. But what is also interesting is that exercises are not only efficient on the symptoms, but it is also cost effective. You can observe on this study that they have clearly demonstrated that neuromuscular strength exercises and aerobic one decrease are cost effective comparing to the usual care, meaning visit in the GP with drug prescriptions. Well, some words now on the diet, because more and more studies demonstrated that to have a beneficial impact on osteoarthritis, you have to do 2 things. To increase the consumptions of Mediterranean diet and to decrease the consumptions of ultra-processed food. This is the key message. And this was clearly demonstrated by this team managed by Veronese and collaborators, is that if you consume 2 or 3 times per week a Mediterranean diet, including, for example, vegetable, poultry, and something like that, you have an important effect not only on the pain, but also on the structural changes of the cartilage, on the lesions of the cartilage associated to osteoarthritis. And inversely, if you consume ultra-processed food, at least regularly, this means sometimes during the weeks, you have a negative impact not only on the pain, on the symptoms, on the function of your joint, but you have also a tiny cartilage. This means that you are more exposed to develop osteoarthritis. This is an easy and clear message to deliver. Less processed food, more Mediterranean food. Finally, some words about the psychosocial approach. And at this time, you have here a list of the different psychosocial methods that have been tested in OA populations. Probably that the psychologists know that better than me, but you have also counseling, education, mindfulness, mentalization, a lot of technique currently used by psychologists. And what is very interesting to note is that this meta-analysis clearly show that if you use this technique, you can not only improve the pain and the symptoms, but also improve the self-efficacy. And this is probably also a key target for the future if we want to improve the NPI effect, is to work on the self-efficacy and the self-management, of course. Well, the problem is that I hope that you are now convinced that NPI are useful to treat OA patients. The problem is that these techniques, these methods are poorly or rarely prescribed and used. For example, I would like to give you some numbers. In Belgium, 31% of the GP, only 31 patients of the GP refer patients with knee-OA to a physical therapist. In France, only the half of the GP recommend rehabilitation for a patient with a lower limb OA. And in a recent survey that we have performed with the French Association of Patients and the Osteoarthritis Foundations, we have clearly demonstrated that 76% of the patients were aware about the benefits of the physical activity, but only 36% say that they are ready to practice physical activity. Well, in conclusions, the first thing is that use pharmacological treatments only to facilitate the rehabilitation and physical activity, to control the symptoms, to allow the patient to return to active treatments. Do not substitute pharmacological treatments for structural exercises program. This is unfortunately too often the case, is that the physicians prescribe drugs without associating NPI. Chronic use of NSAIDs is dangerous and no more efficient than NPI. Exercises are as efficient as painkillers and cost effective compared to usual care. Use education to promote the benefits of NPI exercises and increase the adherence of the patient to the program. And finally, prescribe a multimodal program of exercises. Well, before let you asking questions about my talk, I would like to remind you that each September 17, this is the World Osteoarthritis, and I invite you to launch initiative. And if you want to contact me or know more about my research work, scan the QR code. Thank you very much.
Thank you so much, professeur HENROTIN. Des questions in French, in English, feel free. Allez-y en français, en anglais, comme vous le sentez. Je me permets de lancer le bal, peut-être. Vous avez parlé des différents types d'exercices. Pouvez-vous nous dire quelques mots sur l'aquathérapie? Est-ce que c'est toujours quelque chose qui est indiqué et utile pour ces patients-là qui souffrent d'arthrose?
Alors, donc, pour être clair, dans l'algorithme de l'ORC, c'est une modalité qui doit être utilisée en seconde option de l'action centrée sur le patient. D'accord ? Donc ce n'est pas la première option thérapeutique, mais en cas d'échec, elle peut être proposée et aussi en fonction des préférences des patients. Tout le monde, évidemment, n'aime pas être allé dans l'eau et donc c'est parfois une barrière. Et donc c'est une des raisons aussi pour lesquelles ça vient en seconde option. Mais il ne faut pas hésiter, en effet, à recommander ce type d'exercice qui, comme vous le savez, on peut bénéficier à la fois de la thermothérapie apportée par l'eau, mais aussi du fait que ça soulage évidemment les contraintes sur les articulations.
Est-ce que ça reste toujours indiqué si l'ostéoarthrite est extrêmement évoluée, avec par exemple des patients avec des cannes? Est-ce qu'il y a un moment où il y a une bascule et où du coup l'activité va être plus néfaste que positive ou pas?
Alors ça c'est une excellente question. Je vais essayer de ne pas être très long parce que c'est vraiment une question qui me passionne. Vous avez vu que les recommandations sont très claires, elles ont raison d'être claires. C'est quelle que soit la sévérité de la pathologie, il faut absolument conseiller et instaurer dans la vie du patient un programme d'exercice. Selon le bilan évidemment fait par le kinésithérapeute ou le médecin, on choisira évidemment le type d'exercice qui est le mieux indiqué pour la personne plus âgée ou pour la personne qui a une arthrose sévère. Mais je vais vous raconter une expérience très personnelle. C'est que moi, je souffre d'arthrose de stade 4 depuis maintenant plus de 15 ans. J'étais un candidat à la chirurgie. J'ai appliqué exactement les recommandations. J'ai fait de la musculation, j'ai corrigé tous les systèmes de compensation, j'ai entraîné mon muscle, enfin mes muscles périarticulaires, et je peux vous dire que ça fait 15 ans que je n'ai plus mal à mon genou, et je suis parfois étonné, c'est que je ne sais même plus lequel de mes deux genoux était le plus atteint. Mais donc, tout ça pour vous dire que oui, il faut faire de l'exercice, quelle que soit la sévérité, et je pense que l'on pourrait sauver beaucoup de patients de la chirurgie si on appliquait régulièrement cette recommandation. Et vous savez, je dis souvent, hein, les articulations, c'est comme les dents. Hein. Les dents, on est arrivé à implémenter dans l'hygiène de vie, de se brosser les dents plusieurs fois par jour. Eh ben, pourquoi pas implémenter dans la vie des patients des petites sessions d'exercice, des exercices très simples qui peuvent reproduire à la maison à n'importe quel moment, même en regardant la télévision, mais pour qu'ils entretiennent leur musculature et qu'ils protègent leurs articulations, certainement. Merci d'avoir posé cette question.
Yves, thank you very much for this great presentation and for promoting NPIs in treatment of osteoarthritis. We have a very nice collaboration with the Department of Musculoskeletal and Sports Medicine at the University Hospital in Slovakia. And this collaboration was about the fact that they are so good surgeons that they have nowhere to improve, so to speak, you know, that the surgery is so advanced with the total joint replacement for knee and hip osteoarthritis. And they discovered, or from the practice they saw, that people who were in better psychological state, less anxiety, less depression, and less stress before the surgery, had a better recovery period and less complications after the surgery. So that's why they invited us for collaboration. But actually, this is just a comment, and we are doing a research now whether it works really. And the question is that these surgeons are pushing the surgery to earlier ages. So what do you think about it? Is it okay, or you would promote more NPI, or, you know, to push it a little bit later? So I would like to just hear your opinion about it, how to convince our colleagues to use more systematically NPI before the surgery.
After that, I will be bad mood because you know this is really one of reasons, motivation for my fighting with the Osteoarthritis Foundation, is that clearly they are too much use of surgery. Why? Because they use as criteria for selecting the patient only the X-ray or the imaging and the structural modifications. And when they see that there are decrease of the cartilage thickness or no cartilage, no more cartilage, okay, they say surgery. There is only one option. This is the surgery. And I'm not agree with that, of course. And this is for which in Belgium, with the ministry, we have no guidelines for the surgeons. And if they respect the guidelines, but I'm not sure they do that, they have to promote 3 to 6 months of conservative treatments before thinking of surgery. And this is a key message. This means that you have to perform not only physical rehabilitation, but also psychological treatments before the surgery, not only to expect to save patients from the surgery, but also to improve the prognostic of surgery and recovering after the surgery.
Je pense qu'on va, s'il n'y a pas d'autres questions, passer à la prochaine personne conférencière. Ça suscite décidément beaucoup de questions et d'intérêt.